Hi, everyone. This is Professor Widener. Today, I'm going to go over Chapter 6, Fluids, Electrolytes, and Acid-Base Homeostasis. I hope that you'll enjoy listening to the lecture and find it useful. And as always, if you have any questions, please just email me and let me know. So before we begin, the important thing to know about the body is that it loves homeostasis. It loves everything to be the way it should be and all the balances and checks in place. So it has compensatory mechanisms if things start to go out of whack that it will put into place to keep the body as close to normal status as it can. If these compensatory mechanisms fail, there are systemic consequences, which we'll learn about, but our body's actually pretty smart about keeping itself in check. So our body is primarily made up of water and solutes. Water's job is to move the nutrients into the cells, the waste products out of the cells, carry enzymes of the gastrointestinal tract, carry the blood cells and those enzymes all around the body. There are two kinds of fluids in the body. There's intracellular, which is in the cells, and extracellular, which is outside the cells. Then there are a couple kinds of extravascular fluids. There's actually three kinds. Number one, there's interstitial fluid, and that is fluid in between the cells. You might have heard somebody say somebody has interstitial edema. Intravascular is inside the blood cells. So when you hear someone say that someone is intervascularly dry, that means actually inside their blood cells, they're dry. And transcellular is between the epithelial line spaces. That fluid is like CSF fluid or pleural fluid that's between the layers of the lungs, or fluid that's around your joints. Fluids are constantly moving around your body to maintain homeostasis, and this is done primarily via osmosis. And osmosis is the movement of fluid across the semipermeable membrane from the area of the decreased solute concentration to an area of high solute concentration. With that movement, it depends upon the hydrostatic, which is the push, and the osmotic pressure, which is the pull. Sodium chloride and bicarbonate determine 95% of the osmotic pressure in the intracellular fluid. I'm going to talk a little bit more about intracellular fluids. Intracellular fluids are rich in potassium, magnesium, phosphates, and proteins. 5% of the intravascular fluids contribute to the blood pressure, which is important to remember. Extracerebral fluid is rich in sodium, chloride, and bicarbonate. And the distribution of the fluids in our body all depends on our gender and our age. Regardless of your gender, if you have more muscle mass, you have more body water. If you have a higher fat composition, you have a lower amount of body water. And if you have obese patients, they are more prone to these imbalances because of the decreased amount of body water, which makes them high risk for dehydration. Newborns and infants have a water concentration of about 80%. Their compensatory mechanism is not 100% developed for a few months after birth. So if they get any diarrhea or hypovolemia, those little ones need to be monitored very closely because their systems are not fully developed. Then when you age, you have decreased muscle mass, which means you have more fat and decreased water. So that compensatory mechanism declines as you get older. And an example of that would be chronic kidney disease. Your kidneys are one of your main compensatory mechanisms that just doesn't work well as it gets older. So with this, we have to be careful to avoid serious food imbalances. So fluid and electrolyte imbalances are disorders with intake or secretion. The imbalance exceeds the body's ability to compensate. The kidneys are the primary regulator of this, and it's often a reflection of an underlying disorder, such as congestive heart failure, cirrhosis, or pituitary issues. The main cause for all of these disorders that we're going to talk about is to identify the underlying cause. You can never go wrong if that's a test choice. Underlying disorder is the main treatment to fix all of these. Most of the times these issues are transient and they do not present any problems. However, when it involves potassium and sodium, high or low, these can be life-threatening, and we're going to talk a little bit more about those in a few minutes. Fluid regulation is affected by infections, disease, and hormones. We use IV fluids. When you think about how you use these in the wherever you work now, we use those to therapeutically alter the fluid dynamics. So when we use sodium chloride fluid, by the end of this, hopefully you'll have a little bit better understanding of why we do that. Fluids can also be provided by food and drinking, and fluids are lost in the urine, feces, and insensible losses. And what we mean by that is when you perspire, you may have some insensible losses when you have a fever, a respiratory disorder of some, like an infection of some type, or you can even lose a small amount of fluid through vaginal secretions. The electrolytes are found in minerals, in the blood, the urine, and the body fluids, and they both have electrical charges. There are normal values of electrolytes on page 254 in your book on table 6.1. Those are important to know. You probably have an idea of those already from your clinical experience. But the main extracellular fluids are sodium, chloride, and bicarbonate. And the main intracellular fluids are potassium, chloride, and magnesium. The electrolytes are critical for muscle and neural activity, acid-base balance, and fluid balance. That's another screen talking about the same thing. We're going to talk a little bit now about water, chloride, and sodium. These all work together in the body. And chloride attaches to sodium with a change in chloride and a change in sodium. The sodium concentration goes up and down, which determines the amount of fluid in the extracellular fluid space. Edema is often caused when fluids shift from the intracellular or interstitial space, and may also occur when someone has hypovolemia. It's important to understand the terms for volume imbalances and intravascular compartments. When someone is euvolemic, that means we think that their fluid balance is even and in check. If someone has hypervolemia, that's consistent with volume overload. And if someone has hypovolemia, that again means that they don't have enough fluid, and treatment of these depends on the underlying cause. Sometimes you'll give fluids, sometimes you'll restrict fluids, sometimes you'll give someone Lasix, sometimes you just need to encourage someone to eat more protein so their albumin goes up. So again, just think about the underlying causes. The compensatory mechanisms that maintain fluid balance involve the suppression or secretion of the hormone from the osmoreceptor cells. So for example, if there's increased osmolarity intravascularly, that triggers the thirst mechanism in the hypothalamus to increase oral intake. The best way to prevent water loss is through ingestion. Although the tricky thing is as people get more older and their compensatory mechanisms don't work as well, older folks tend not to be as hydrated, which is called hypodipsia, meaning simply that they just don't drink enough or they don't have the same thirst mechanism. ADH, or antidiuretic hormone, also called vasopressin, is a mechanism that regulates the water through excretion of ADH, either increases or decreases from the pituitary glands. It promotes reabsorption of the water and shifts blood into the renal tubules. ADA suppression increases water loss, and the volume status changes then go into activation. Within the kidneys, you see this as decreased volume and decreased perfusion and activation of the renin-angiotensin-aldosterone system. Within the pressure senses of the vascular system, you'll see these changes in the aorta and the carotids, and it will also activate the sympathetic nervous system. In the heart, you'll see the something called the brain neutropenic peptide, which you better known as the BNP. That is a peptide that is released when the ventricle is stressed. When the atrium is stressed, that releases an atrial neutropenic peptide, but I've never actually seen that one measured. But again, when the body is under stress, these are the different compensation mechanisms that it uses. So when someone has fluid excess, the most common cause of this is too much restraint of sodium with the water. This occurs in different compartments of the cells, either interstitial or intercellular or transcellular. And this also leads to the concept of third spacing, where the fluid is out of the cells and into the tissues. There is a table on page 256 that goes over the disorders of fluid excess and deficits. And that's something that that table summarizes everything we're going to talk about, but it's table 6.2. Fluid excess is often a problem with fluid distribution and not necessarily volume overload. However, in the course of edema, that is when the hydrostatic pressures are greater than the osmotic pressures. And this impacts the venous system, where we see fluid retained, the water sodium balances are off, venous insufficiency. And sometimes we see increased edema in the body as well from calcium channel blockers and Lyrica. So calcium channel blockers are notorious, especially Norvasc, for causing lower extremity edema. And sometimes that's why people discontinue them, because of the lower extremity edema. When someone has water intoxication, this means that the intravascular water concentration and the dilutional sodium cause the water to shift into the intercerebral fluid, causing the cells to burst. The cerebral cells may be very sensitive to this. This can be done, there is a psychiatric disorder where people drink too much fluid, water, than the body can deal with at times. And it also impacts the body's excretion abilities. When we're looking at edema, we want to describe that by the location. And is it unilateral or bilateral, which can give us some underlying thoughts about what the cause might be. Is it acute edema or chronic edema? Like for instance, after pregnant women have edema, sometimes after they deliver, that's acute edema. We expect it to go away. But someone who has lymphedema, we know that it is chronic. There's also dependent and non-dependent edema. When someone has edema, it can also be described as pitting or non-pitting. So those are the different characteristics that help you think about what the issue is. If someone has bilateral lower extremity edema, that tells us that there's likely a systemic issue, which, as we know, is congestive heart failure, or another one is that's less common, but is out there, is hepatorenal failure syndrome. Notoriously, if someone has a unilateral leg that is inflamed and red and has edema, that makes us concerned for a DVT, so you'd have to rule that out. And a lot of times with infection, we can see that the area that is infected has a larger area of edema as well. And the other thing is, like, if you hurt like your ankle, just that area of the ankle that you hurt could have edema in it. But again, it's the body's way of healing itself. So the clinical manifestations of edema, of fluid excess, include edema, dyspnea, a bounding pulse, tachycardia, or hypertension. Bounding pulse means you can really, really feel it. When you hold it, you'll feel that bounding sensation. Jugular vein distension, crackles on physical exam. And in infants, you'll actually see bulging fontanelles on the top of their head. The causes of this fluid excess, again, can be systemic issues like congestive heart failure. There can be, it can be generalized, which would mean something like anasarca, where there's just body, extra fluid all over the body. There can be cerebral edema, and the signs and symptoms of that would be a headache, nausea and vomiting, sudden onset of anxiety or irritability. And again, diagnosis is basically based on physical examination, and the treatment is to manage the excess fluids, but again, also find the underlying cause. The management of these fluids would have the goal of moving fluids from the interstitial to the intravascular spaces with water restrictions. Sometimes there's sodium restrictions, sometimes it's diuresis, whatever that would take to fix that. Now we're going to move along to fluid deficits. This is when the total body's fluid levels are insufficient to meet the body's needs. The most common cause is too little sodium and the ability to retain the water. Dehydration is when you have water loss resulting in hypernatremia. And it's important to know that's just water loss. When you have hypovolemia, that is a deficit of sodium and water. That fluid deficit is in the intravascular compartment, and the result is total volume loss for the body. Water alone will not increase the sodium. I'm sorry, water alone and the sodium is how you fix hypovolemia. When someone has fluid deficit, specifically the intracerebral fluid cell, dehydration leads to a hypertonic state in which the cells start shrinking. And as the fluid shifts from the intracellular fluid to the extracellular fluid, this can also cause the brain cells to shrink. So that's why when you're rehydrating someone, if their sodium is very high and they have a fluid deficit, you want to do that very slowly because of that shift in the fluids. When the brain cells rehydrate, we don't want them to expand too quickly. This can be manifested as thirst or altered levels of consciousness, but some of the other signs and symptoms are dizziness with movement, tachycardia, a flat jugular vein, sunken fontanelles in infants. And if you think about looking at the older patients, again, that we treat, they have decreased skin turgor. They have those dry mucous membranes. They don't make a whole lot of urine, and they show weight loss. So the fluid deficit is diagnosed based on the physical exam, looking for some of those characteristics that we just talked about, and determining the cause of that underneath. Sometimes it might be diarrhea. Sometimes, someone may come into the ER with very bad nausea and vomiting for several days. Sometimes we see in my practice, someone come in, an older person, because they fell and they haven't had anything to eat or drink in a few days. So treating the underlying cause is really how you'll fix the fluid deficit. So now that we understand a little bit better about the fluids, we're going to talk about the electrolytes, and these are important to understand. And I really like that this book, each electrolyte has a chart where they summarize the signs and symptoms and the treatment. Again, remember, most of the electrolytes can cause neuro problems. So when you're studying for the test, really focus on the ones that are in black, that are kind of the more prominent ones. So first, we're going to talk about sodium. Sodium is the most prominent or significant cation, is the most prevalent electrolyte in the extracellular fluid, and its primary function is to control serum osmolality and the water balance. It helps maintain this acid-base balance when it's combined with bicarbonate. Sodium has an affinity for chloride and helps maintain acid-base balance when combined with another anion, such as bicarbonate. Based on the volume status, increase or decrease in sodium is controlled by aldosterone, which is made by the adrenal cortex. Aldosterone releases in the kidney and tells the kidney basically whether to retain sodium or excrete it. When sodium needs to be released, the sympathetic nervous system increases glomerular filtration rate. The sodium potassium pump is also controlled through this, and this transports sodium and potassium across the cell membranes. Cellular membranes are permeable to sodium, but dependent on the sodium potassium pump to transport these ions. Sodium also facilitates nerve and muscle impulses through the pump. When sodium is present and goes into the cells, potassium goes out of the cells, causing depolarization. And when sodium moves out of the cell and potassium moves back into the cell, that's called repolarization. And that'll be important to know when we get to the cardiovascular section. Sodium is brought into the body primarily through dietary intake. We see hypernatremia as a result of high serum sodium levels. And again, that would be over 145. Hyponatremia is the result of a low serum sodium level. I want to talk a little bit about hypernatremia. There's basically two scenarios that happen that are possible. In one scenario, there's a loss of sodium with even greater amounts of water causing hypovolemia. And the other scenario would be there's excess water relative to the sodium loss, such as when you have diabetes insipidus or TPN, hyperalimentation. When you find hyponatremia, that's a sodium less than 135. As the serum osmolarity drops, water shifts out of the extracellular fluids to the intercellular fluids. This causes the brains to swell, causing cerebral edema. Disorders that lead to a low sodium are renal failure, severe volume depletion, diuretics, specifically the thiazide. So if you have someone on hydrochlorothiazide for their blood pressure, which is the first line blood pressure medicine, you usually want to check labs like 2 weeks after that, because you want to make sure their sodium isn't too low. There can be lack of sodium intake and not enough water. There can be a decompensated congestive heart failure and nephrotic syndrome. The primary clinical manifestations of this are hypernatremia, which is lethargy, headaches, confusion, irritability, seizures, and a coma. And often with hyponatremia, we see similar neuromuscular manifestations. And usually if they have a gastroenterology issue, their sodium is below 130. There's a interesting disorder called beer photomania. So if you have someone who's a chronic alcoholic who drinks a lot of beer, their sodium usually live like in the 110s. So again, they're going to come in that way. So it's important when you rehydrate them to do it slowly so their cells don't burst on them from the moving back of the fluids. But it's kind of an interesting disorder when you see it. Again, the diagnosis is based on blood work, and the management is treatment of the underlying conditions. All right, so that's sodium. Moving along to chloride. Chloride is an electrolyte, a mineral electrolyte, and it's a major extracellular anion. It works with sodium in the sodium chloride pump, found in gastric secretions, pancreatic secretions. It assists with fluid distribution. Its main source is dietary and is excreted in the urine and with some sweating. Hypochloremia and hyperchloremia typically have no real distinct clinical manifestations. You probably have not seen someone specifically diagnosed with this, but it can impair, again, the fluid balance. The diagnosis is usually made by, again, it's always going to be history and physical exam and blood chemistries and a urine analysis that will help you with that. And a blood gas is also helpful with this, because when you have low chloride, you may have metabolic alkalosis with acidosis, like a mixed disorder. The treatment is, again, we're back to underlying causes, and that would be diuretics and the administration or removal of bicarbonate. Moving along to potassium. Potassium is the primary intracellular cation. It plays a role in electrical conduction of all over. Specifically, we think about this as in our heart. It helps maintain acid-base balance and metabolism. Serious issues can result from the fluctuation of that. Dietary, again, is the main source. However, if you have someone on diuretics or something like that, you may need to supplement their potassium as well. Normal potassium is 3.5 to 4.5. Hyperkalemia is considered to be a serum level over 5, and hypokalemia is a serum level less than 3.5. And again, remember to check your book for the different list of everything that you'll need to know about this. It just summarizes them in a nice table that's easy to use. All right. So imbalances in potassium can affect several body systems, and a chemistry panel or the NP is usually the diagnostic test for this. And again, treatment revolves around the underlying condition. If someone comes in dehydrated, they very well may have a low potassium. Someone who is on a potassium sparing diuretic may have a really high potassium and need treatment for that. So the treatment revolves around increased excretion of it and treating the acidosis that is usually associated with it. And hypokalemia involves replacing potassium either orally or intravenously. I'll give you a little tip that for every 0.1 you want the potassium to go up, you need 10 milliequivalents of potassium. So if your potassium is 3.2 and you want a potassium of 3.5, you would give someone 30 milliequivalents of potassium to replace that. Just a little tip there. So that's potassium. We'll talk a little bit more about the specific managements when we go through the acute and chronic classes and things like that. The important thing right now is just to have a general idea. Calcium is found in the bones and teeth. This is important because the remainder of the ionized potassium is found in the blood. It bounds to albumin and chelates with phosphate, citrate, and sulfur. It has an inverse relationship to phosphorus and a synergistic relationship with magnesium. So what that means is that in order to fix a low magnesium, you also need to fix the calcium. It is reabsorbed through dietary sources in the GI tract. It is excreted in the urine and stool, and it's regulated by the parathyroid hormones and calcitonin. Hyperkalemia is a level over 10.3, and hypokalemia is a level under 8.8. The clinical manifestations of this are often nonspecific. They may feel nothing. They may feel an imbalance that affects cells' excitability. They may have some tetany as a source of hypokalemia. And you can also check Trousseau's and Chivok's signs. The diagnosis is, again, made by history and physical exam, some blood work and a 12-lead EKG. The reason that calcium is important, obviously, for the maintenance of our bones, but if someone comes in to your practice and they're not feeling well, they have other things going on, and you check some blood work and they have a really high potassium, like a potassium over 10, 10.3 is normal, but sometimes you see potassiums of 12 or 13. When you see extreme potassiums, that makes you concerned that there's an underlying malignancy. Now, if you're in the hospital, we try to acutely fix that with some fluids, but if it does not fix, we go looking for an underlying cancer disorder. Unfortunately, sometimes that's an initial symptom. So phosphorus plays a key role in bone and tooth mineralization, cellular metabolism and acid-base balance, and cellular formation. Again, diet is the main source. Hyperphosphatemia is above 5.4, and hypophosphatemia is below 2.5. The manifestations are similar to a potassium imbalance. So it's important to use your diagnostic procedures of a history and physical and blood chemistries to help narrow down which it might be. To treat hyperphosphatemia, you may use aluminum hydroxide or aluminum carbonate. And to treat hypophosphatemia, you could use oral supplements or IV potassium phosphate supplements. But again, if you use IV potassium phosphate supplements, remember, there's still potassium in there. So if someone has a high potassium and a low phosphorus, they make another concentration called IV chloride phosphate. So you'd want to use the chloride instead of the potassium. So just remember, if you're ever using something that has two electrolytes in it, the patient is also getting that other electrolyte. Last but not least, we have magnesium. This is an intracellular cation that is mostly stored in the bone and muscle. The functions of magnesium are to help with muscle contractions, which is why sometimes if you're, again, just trying to relate this to your acute experience, if you see someone having a lot of ectopy on their heart or a lot of PVCs, or even atrial fibrillation that's new, sometimes that is because their magnesium is too low. So again, the heart is a muscle, so that low magnesium is interfering with muscle contraction. Diet is the main source, and hypermagnesium is a level over 3, and that's usually caused by renal failure or excessive intake. And hypomagnesium is a level under 1.8, and that is often caused by inadequate intake or decreased absorption. Clinical manifestations of this include the neuromuscular manifestations in the cardiovascular system, again, mostly focusing on the muscles. Diagnostic procedures include a history, a physical exam, and blood chemistries. For treatment of hypermagnesium, which I've never actually seen, but if you had to treat it, you could use diuretics and IV fluids. And to treat hypomagnesium, you can give either oral or IV supplements. Oral supplements are fine if they're not having any symptoms, but obviously if they're having symptoms, you would want to use IV supplements, which if they were in the hospital, if they were in your office and having symptoms, you could send them to the hospital, get some IV magnesium. All right, now we're going to talk a little bit about acid-base balance. This is crucial to maintain life and maintain your health. Remember, your body wants hemostasis, so this is achieved through buffering system and compensatory mechanisms. The main players in this are the body fluids, the kidneys, and the lungs. Normal pH is 7.35 to 7.45. There is certain death if your pH goes below 6.8 or rises over 7.8. The changes in pH can be multiple. They are often caused by infection, though, organ failure, or trauma. And we're back again to find the underlying condition and treat it. Administering sodium bicarbonate is controversial. Sometimes it's done, sometimes it's not. But usually the best thing is to hydrate and treat the cause. So the pH represents a negative algorithm that reflects hydrogen concentration. So the more hydrogen there is, the lower the pH. Hydrogen is necessary for maintaining cellular membranes and enzyme activity, and it produces acids as a byproduct of this system. The acids produced as the byproduct of metabolism of protein, carbohydrate, and fat. There is a buffering system and during buffering, the acid base balances are exchanging. So they're switching either acids and bases to again have this counterbalanced pH. Carbonic acid and bicarbonate CO2, which is an acid, is a byproduct of cellular metabolism. CO2 then diffuses in the blood. It reacts with water to form carbonic acid. The carbonate acid decomposes rapidly to form hydrogen ions and bicarbonate. In the lungs, this is reversed, where bicarbonate is expired along with the water. There is also a protein system that can act as either an acid or a base. And here albumin and other plasma products can also act as part of that. And this is the primary buffer system in the extravascular space. There is the phosphate system as well, that it can act as a weak acid or base. The phosphates in high concentration in the intracellular fluid either act as an acid or a base based on, and this is controlled by the kidneys. And the movement of potassium and hydrogen maintains the pH balance. So we're talking about respiratory regulation. The lungs remove acid through the elimination of carbon dioxide, but cannot remove the other acids. The important thing to know is when you're trying to fix an acid problem, the respiratory system will act first. It's the fastest one that adapts to pH, and it is a short-lived adaptation, usually for about 12 to 24 hours. So again, if you use your own experience and if you're working in the intensive care unit or wherever you're working with, and you see a low pH and the pulmonologist makes changes to the ventilator, he's trying to adjust that pH through changes in the ventilator because he knows that the respiratory system adapts first. The renal system adapts as well, but it takes a longer time. So there is increased ventilation and higher excretion, which decreases the acid levels. And then if we decrease the ventilation and lower the excretion, the acid levels increase. These changes are triggered by chemoreceptors sensing pH and PCO2 fluctuations and can obviously be controlled by a mechanical ventilator. As far as renal regulation, the kidneys are the only organ that can remove hydrogen ions. As we said, it's the slowest acting to react to these changes. The kidney excretion or retention of hydrogen or bicarbonate. The kidneys excrete non-volatile acids as well. Urinary buffers necessary to eliminate hydrogen are phosphate and ammonia. They attach to the hydrogen ions to be sure that it is excreted in the urine. So when we talk about compensation, there's an adjustment of the pH within normal range. The body will do, again, whatever it needs to do to compensate for those pH changes. These changes are caused by some kind of imbalance, and you have to address the imbalance based on the severity of the imbalance. If we look at the different compensation mechanisms by the respiratory system and the kidney system, that's where we bring in metabolic acidosis and metabolic alkalosis and respiratory acidosis and metabolic alkalosis and respiratory alkalosis. So just as a side note, if you look on table 6.8 on page 276 and table 6.9 on page 277, They give a very nice description of the acid-base balance in a concise format that would help you easily remember this. So metabolic acidosis is a deficiency of bicarbonate and an excess of hydrogen. This is due to increased production or excretion of that. Metabolic acidosis is defined as a pH under 7.35. Its causes include intestinal losses, such as diarrhea or vomiting or fistulas, and renal losses, such as early renal failure or tubular acidosis. Sometimes there is an acid excess within the tissues because of hypoxia from sepsis, shock, or cardiac arrest. The manifestations along with the existing conditions are often neurologic in nature that include headaches, malaise, weakness, fatigue, confusion, and coma. When you think about the causes, you can also think about diabetic ketoacidosis. Sometimes you'll see this with excessive alcohol intake, starvation, or extreme diets. The other sign and symptom you'll see is the Kussmaul respirations, which are deep, rapid, and develop in an attempt to eliminate excess acid by inhaling more CO2. Again, and Kussmaul's is consistent with DKA. How you're going to diagnose this, you're going to then do a history and physical. You're going to get an ABG and blood chemistries and a CBC. You want to determine the underlying cause and treat that underlying cause. You want to correct any electrolyte disturbances. When appropriate, administer IV sodium bicarbonate and improve oxygenation. Oh, we just talked about that one, improved it. All right, metabolic alkalosis is a result of excessive bicarbonate because of increased intake or retention of deficient acids. Or it can be a combination of an increase in bicarbonate and deficient acids. The causes of this can be extreme acid use, use of bicarbonate-containing fluids such as LR, nausea and vomiting, NG tube to suction, hypokalemia, renal losses such as renal failure or diuretics, hypovolemia, and hyperaldosteronism. The neuromuscular manifestations are similar, that they include a headache, seizures, but again, you may even have no symptoms at all. You'll diagnose this by history and physical, ABG, blood chemistries, and CBC. And the treatment is, again, to find the other underlying cause, fluid replacement, and correct your electrolytes. Respiratory acidosis results from increased CO2 retention. When CO2 increases, carbonic acid goes up, which decreases the pH. This is caused by hypoventilation or impaired gas exchange. You can also see this with respiratory depression from a brain trauma, oversedation, a drug overdose. Again, anything that kind of impairs your airway. You can see this when someone has a flail chest, for instance, like a traumatic flail chest, they may have respiratory acidosis. You can see respiratory muscle paralysis, COPD, pneumonia, or pulmonary edema. The manifestations of this are a little bit different in that you see hypoxia generally, dyspnea, cyanosis, neurological changes, and behavioral changes. The treatment basically focuses on improving the respiratory status, and that can be by resolving hypoxia and hypercapnia, whether that's adding oxygen or a mechanical ventilator. You want to protect that airway, whatever you can. Sometimes people do have chronic acidosis, and that can be caused by longstanding COPD. Respiratory alkalosis is a result of excess inhalation of carbon dioxide. The conditions include severe hyperventilation and stimulus of the medullary respiratory center. The causes of this include severe anxiety, pain, hypoxia, gram-negative sepsis, aspirin overdose, excessive mechanical ventilation, or hypoxia. It manifests itself as paresthesias, dizziness, syncope, and neuroexcitability. It may be easy to contribute this to a low calcium. So you have to be careful because the signs and symptoms are very different. The treatment involves resolving the underlying cause and again, increasing carbon dioxide levels. There are such things as mixed disorders, and these are usually evaluated by history and the compensatory response of the kidneys and the respiratory system. These are usually common in patients that are critically ill, that you're balancing acid and alkalotic states. And these can also be common in critically ill patients with morbid obesity. On page 281, figure 614 gives a nice little blurb about mixed disorders that would be good to know. As far as arterial blood gas interpretation, this is the diagnostic tool, kind of the gold standard for how we evaluate an acid-base balance. And the important thing to remember is that this is a single point in time. So when you do an ABG, sometimes we do them for baselines to have, especially like in a pulmonary office, a lot of times respiratory patients have a like baseline blood gas, but in more urgent situations, this is how we would use these, and it only represents a single moment in time. The results you're going to get are a pH, a CO2, a bicarbonate, a oxygen level, and a base excess or deficit. When you interpret blood gases, you're going to focus on the pH, the PaCO2, and the bicarbonate for interpretation. We would think that CO2 is an evaluation for base deficit assessment, but it is not. It is important to know the CO2, but not necessarily it doesn't tell us anything about the acid-base balance. So on page 282, there is an algorithm that describes how to do ABG interpretations. You start with a systematic way. You may or may not already know how to do this, but the first thing you look at is the pH to decide if it's acidic or a base. Then you're going to look at the PaCO2 and decide if that represents an acid or a base. And then you're going to look at the carbon dioxide and again decide if that represents an acid or a base. And then you're going to match up the results between the acidity and the alkalinity for the primary diagnosis to figure out how to best treat it. So for instance, if kind of the classic one I would want you to think about is your COPD patient. You're at the hospital, you walk in, this person's here with pneumonia, but they have an underlying COPD disorder, and you were in there an hour ago, they were doing fine, and now you go in and you kind of find them slumped over and they're real sleepy. When you're moving to the next step of your career as learning how to be a provider, one of the things you have to think about is their CO2 high? And as that acid level, remember CO2 acts as an acid, as that acid level goes down, because the CO2 is getting higher, that causes those neurological changes. So that would be a reason to get an arterial blood gas. So that would be an example of respiratory acidosis. So then if we know it's caused by the high CO2, we would correct that. And then the person will wake up more and those neurological symptoms would resolve. So I hope that that has helped. If you have any questions, please let me know. I'm happy to answer them. And I will have office hours next week, or if you need a personal appointment, just shoot me an email and we can make that happen.